And here we go. Thank you for joining us today. We are here with Dr. Breeze, who graduated from Northwestern University with a Bachelor of Arts degree and honors in English. She then earned her medical degree from the Baylor College of Medicine. She completed residency training and family practice at Memorial Hermann Southwest, where she received the Norma Culver Outstanding Family Practice Resident Award. After working in private practice for some time, she left clinical practice and served as the CEO of Richmond Bone and Joint Clinic. And currently, she developed several medical organizations, including a rehabilitation hospital and several surgical centers. In 2011, she partnered to launch Vantage Hospice and a healthcare-based here in Katy that provides end-of-life care to patients throughout Greater Houston. In 2013, she founded Next Level Urgent Care and serves as CEO. Next Level Urgent Care provides after-hours and weekend non-emergent care, as well as employer programs to decrease cost of employee health care, kind of what we're going over today. There's a number of locations across the Greater Houston area. Is it 15?
16 now, about 16.
Awesome, 16 now. In the Houston region provides on-site medical services to 5 large Houston area employers. Dr. Breeze and her team are partnering with a number of organizations and employers to create customizable, cost-effective solutions for the best care of their employees. So thank you, Dr. Breeze, for being here. I'm going to put myself on hide, and we will go from there.
All right. Well, thank you very much for having me today. I appreciate the opportunity to talk to you. And as you may know, this is a webinar, so I cannot see you. So feel free to eat your lunch. I recognize that this is sort of prime time for eating, and I can't see what you're doing. So go ahead and do what you need to do. Hopefully I can give you some interesting information. This talk is really for people who are interested in, first of all, what is driving our healthcare costs up, but also really it's focused on employers who are providing healthcare solutions to their employees, and what else is out there and what can we do. Because you know, I am in the healthcare field, and I feel very lucky to be, you know, both a physician and a business person in healthcare. But primarily these days, I'm a business owner, and I have about 350 employees that I am kind of in charge of at Next Level Urgent Care, and I need to provide them with great health care. And so I feel like I can see all sides of this, these issues, because I'm both the employer providing health care, and I'm also the provider of health care. So my perspective is just a little bit unusual. So today, hopefully I'll be able to cover a lot of different things. I'm going to start by basically just talking about why should you listen to me? What qualifies me as an expert on affordable healthcare? Well, not a lot, but I will tell you what I have done. So what I have done is actually most recently in 2013, when I launched Next Level, it was out of frustration. And my frustration was that there were freestanding emergency rooms popping up all over town, and people didn't understand that they were a very expensive place to get care. And so I created Next Level as a solution that was about 10 times cheaper than going to those freestanding emergency rooms and receiving, you know, urgent care services. So that was my sort of first kind of commitment, full commitment to how do we contain cost and still maintain quality in healthcare. But before that, a couple of years before that, Matt mentioned that I ran Richmond Bone and Joint Clinic. Well, Richmond Bone and Joint Clinic was privately held, and we were providing care. We were doing fine. It was a good business, and it provided a good service. But when we decided that we needed to sell, we felt that it was time to basically have a hospital or a healthcare system take us over, because we had gotten very large. We had 20 physicians. And at the time, there was a lot of consolidation. A lot of physicians were being hired by hospitals. And in that consolidation, we felt that we might be left out. And because orthopedics is a surgical specialty and we need hospitals to do surgeries in, we felt that not teaming with a hospital would be a bad idea. And so when we made the transition from going from Richmond Bone and Joint to being a hospital-owned practice, a couple things happened overnight, which I thought were fascinating, and actually I think probably, contributed to how I feel today about, the how much interest I have in what drives healthcare costs. But what happened was that overnight we had the same exact stuff. We had the same MRI, we had the same facility, we had the same people operating everything. Nothing had changed. But on the day that we opened as the hospital-owned entity, our MRIs went from costing $440 a piece to costing over $1,200 a piece. The other thing that happened was that our physical therapy visits went from costing $60 to costing $180. And this was what was most fascinating to me about the change, was that no one said anything, nothing. There was no screaming, there was no, this is unfair, there was no nothing. And why is that? Well, because for the patients who were actually receiving the service, their copay was pretty much the same. They didn't actually feel the difference. Plus, they hadn't come the day before to get an MRI. They just came that day. So the price that they got was what they assumed was the price. And so there was no uproar about this big change in the pricing. Well, it got me thinking, so if the patient isn't really affected by these changes in price, who is? Who pays these bills? And if you are a self-insured employer, well, then the answer is you. So self-insured employers were basically going ahead and receiving these big changed bills, and not really knowing what happened either, by the way. You can't really, I don't look at every bill that comes in. I'm a self-insured employer, but I don't look at these bills and I don't compare them to what my employee got at that same place last year. So basically the whole thing went largely unnoticed. And so what I want to say about why I feel like I'm particularly the right person to talk about affordability in healthcare is that I have seen things that many people don't even know happen in healthcare. So today we're going to talk specifically about the drivers, the things that are happening right now that are making healthcare more expensive. And obviously the list would not be complete without starting with pharmaceuticals. I'm sure if you are listening to the debates, if you're reading the papers, you know that drug costs are astronomical in our country, and we'll talk a little bit more about that in a second. Emergency room usage, of course, is my favorite topic, because part of the reason that we launched Next Level was to address this. Out of network usage, this is something that has become it's been addressed quite a bit in our state legislature, but it's still a big problem for employers. Inpatient hospitalizations is a big cost driver in the ultimate care. We can do a lot of things as employers to reduce the costs of our care, but if we get one employee that gets a bad cancer diagnosis, or one employee that ends up in the ICU for cardiovascular disease or out of control diabetes, it's an incredible amount of cost. Not to mention premature deliveries. Preemies are a really big, expensive driver of cost. COVID's new to the list, a late arrival here, but it is going to be definitely a driver. It's a driver right now, and it's going to be even more of a driver in the future. I think I'll talk about that too. And finally, our fee-for-service structure is antiquated and isn't appropriate for affordable healthcare going forward. And I'm going to talk quite a bit about that as well. So I'm going to jump into this, and by the way, I think that you can send questions to chat. So if you have anything that is a burning question, please send it, and at the end we'll address the questions that we received. So first of all, let's talk about medicine. So one of our big problems in the US is that we have been convinced as a culture that we need medications. And in the US, we spend almost $1,000 a person per year on medicines. And that, how do you even, understand that? Well, in a relative sense, the next country that is the biggest drug spender is Canada, and they spend 40% less than we do. So we're 40% higher than the next closest country. We spend 2 times as much on medications as France and Germany. Ooh, you know what? I'm going to go back for a second because I have a feeling that I have a runaway presentation here. I will say that when it comes to medications, we're really what we're worried about is that the more medicines that people take, the more medicines they need, because actually we've kind of proven that polypharmacy is actually a big cause of illness, and so this is sort of a compounding effect. We start taking medicines and we need more medicines. And there is in our country just a really big problem because we don't limit the margins. In other countries, they limit the margins that drug manufacturers can make on a single medicine, and that actually keeps it in check. And here we do not have that. So, more on drugs, the question is, why don't we do anything? Why don't we just prescribe less, or why don't doctors pick less expensive medications? Well, one thing that I think many of you probably know, but is definitely an important issue, is that all of us as employers choose a drug plan, and they're all different. And I can, as a self-insured employer, choose even what my formulary looks like, what drugs are covered, what drugs are not covered, and things like that. So when there's no way that an individual physician could know what drugs are most cost effective under my plan. It's just a level of detail that we are not exposed to as physicians. So physicians really are unable to help with that. Now, sometimes pharmacists will jump in, and we'll get calls from pharmacies, hey, you prescribed these eye drops, but actually on this patient's plan, the other eye drops are less expensive. Do you want to change? And of course we do. We're not trying to drive up the cost, but if a pharmacist is, busy doing other things, they may let that go. And so, again, this is sort of a cost that some of it doesn't even make any sense. The medications are equivalent, and either one could be used, but that more expensive is used because there's nobody watching out for the employee. The other thing that, of course, when, I talked a little bit about emergency rooms, I talked about, how I feel about them. I think emergency rooms are really, really important for life-threatening emergencies. I think that there's a lot that is done in emergency rooms right now that has nothing to do with a life-threatening condition and can be easily treated in another setting for far less money. But we don't have anybody helping to guide our employees to get to those places. So they end up, just thinking, okay, where do I go? And it's a panic because it's an injury or it's an illness that's happening that they're worried about. So they run and go to the nearest whatever. And if that's an emergency room, they're going to be paying some huge bills. Just to give you an example, an ankle fracture taken care of in our setting in the urgent care costs about $250. That's x-ray, that's splinting or casting, what have you. If you go to the emergency room, you will walk out sometimes with up to a $6,000 bill for this very, very similar care. So I love this slide. I love showing it because, a friend of mine gave it to me a while back. So one of the problems with emergency rooms is that a lot of them are out of network. Here in Houston, we have a lot of freestanding emergency rooms that do not take insurance. And so when your employee goes there, they can bill whatever they want. And this was a friend who got this bill, and her son had gone to a freestanding emergency room that was out of network. He had a sore throat, and he didn't know where to go. So he went to the emergency room. I think he was like 22 or something like that. And you can see that he got some medicines for $45. He got an IV, a bag of IV fluids for $59. He actually got the IV started for $1,772. That means somebody came and stuck a needle in his arm for almost $2,000. He got some med-surg supplies and some sterile supplies. Who knows what the heck that is? But $150 later, he, they used some supplies. And then they ran a strep test for almost $3,000, $22,943. They charged a facility fee at the emergency room of $2,000. And then they gave a few more drugs here for another $273. After the son called, he was able to adjust the bill. He called and said, I can't afford this. And because it was $7,272 when he started. And they said, no problem, we'll make an adjustment. So they made an adjustment of $4,750, and he ended up having to pay off $2,521 in medical bills for strep throat. This is just an example, and I'm sure you all have probably friends and family members with similar stories, but out of network is an issue, and not just in emergency rooms. Out of network is an insidious problem, because what happens is that sometimes there are physicians who know that their service has to be used, and so they don't have to be on an insurance plan because no one is choosing them based upon insurance. So for example, physicians like pathologists or radiologists who are behind the scenes, they may be out of network at a facility. So I had an experience where I had to go to an emergency room. I thought I had appendicitis. And when I got the bill, I had called and said, are you in my network? And I gave them my insurance, and the emergency room said, yes, we are. Come on in. We take Aetna or whatever it was at the time. And when I got the bills, I had 2 out-of-network bills, one from a radiologist, and can't remember, maybe I only got one. Radiologist sent me an out-of-network bill for the ultrasound read. And I called the ER and I said, well, you said you were in network. And they said, but we are. We can't control what the radiologist does. And so, another way that, patients and people get, unforeseen costs is that they, even when you're trying to do the right thing and trying to make sure that you are protected from out of network, you can still get stung. So, that brings us to the cost driver of inpatient hospitalizations. Why do people end up in the hospital? Well, they end up in the hospital sometimes because they have terribly bad luck, sometimes because they have terribly bad genetics. But there's another reason, and the most predominant reason is that they didn't get optimal care of a chronic condition, or they didn't get preventive care and a condition was caught late. So those are really big drivers of inpatient hospitalizations. And the fact that, we have only 5% of our care dollars are spent on preventive care, where we have the rest of it spent on basically reactive care. That's a problem in our country, and it is certainly a cost driver. I mentioned earlier premature babies being born and NICU as a very big cost in healthcare. Well, that's a known condition, and if you have really good prenatal care, it is proven that you can avoid or mitigate a lot of the problems that you're going to have that are going to drive up hospital bills when that baby is born. Same thing with diabetes and cardiovascular disease. If you are getting very good care all along, you are likely to lessen the blow of a hospitalization for one of those conditions later down the line. But these are big drivers of cost And hospitals, again, pay charge facility fees on top of, very expensive medication fees. If anybody read, um, now the name is on the tip of my tongue. It's something about the jagged pill, but it was an expose on the cost of medications and the cost of care and the supplies costs in hospital facilities. And they look a lot like what I just showed you on the previous slide, with those out-of-network charges. They were charging $80 for a Tylenol and things like that. Now, by the way, that doesn't happen all the time, and there's a lot of really great hospital care. I don't want people to think that I'm hospital bashing. I think that there's like all of this stuff, there is a very, very good reason for us to have excellent emergency rooms. There's a very good reason for us to have excellent hospitals, and that is not my point. My point is that there are hidden costs, and there are costs that as employers we could affect if we really understood and knew about them. So now the next cost driver I want to talk about is COVID. Now this is a kind of late to arrive at the party, but a very important cost driver. So COVID not only has driven up the cost of our, just taking care of people. I mean, we have to put all of our employees in PPE now with the masks and the gowns and all that stuff. And it's a lot more expensive to provide care in this environment. But then as employers, we are dealing with employees that may actually get it and have very lengthy hospitalizations. And this is not a cheap hospitalization. A lot of these people require the ICU, they require ventilation. It can be a complete disaster when it comes to cost. And even if you're an employer that's lucky enough to have avoided having employees that got really bad COVID, you probably are not an employer that's going to avoid the other problem with COVID, which is that most employees have delayed care or foregone care because they're afraid to go into the hospitals, they're afraid to go into the doctor's offices. And so we all believe that as COVID starts to wane as a real health threat or a serious cause for panic, the new cause for panic will be all those people coming in, like I just told you, coming into the hospitals with conditions that could have received better care up front, but they didn't. And so now we've got really expensive care that we have to provide for conditions that could have been taken care of more easily. The level of care is very important. So these days, since COVID, we have even more choices for where patients can get care. So patient can get care in a virtual setting. They can get care in the retail setting. They can get it at their PCP, the urgent care, the ER, the hospital. There's a lot of different choices. And most of us are not very well educated on when a particular choice is appropriate. Well, that's a very big problem because it can drive up cost if a patient chooses the wrong level of care. The obvious example of that would be a person who chooses to go to an emergency room when they could have been treated in the urgent care or in their PCP's office or at a retail clinic. The less obvious example of this is what happened a lot during the initial COVID months, where we turned on telemedicine as an organization. And one of the things that happened was a lot of people were trying to use telemedicine that actually really needed to be in the emergency room or really needed to be in a facility where they could get a chest x-ray or they could get a pulse ox or they could get oxygen or whatever they needed. And so what happened was the fact that the patient chose the wrong level of care delayed their treatment, or it resulted in 2 visits when it could have been 1 visit. And so those things happen. So whether you're choosing wrong up or choosing wrong down, it's still choosing wrong and it's still driving cost. So the final think, yeah, this is the final cost driver I'm going to talk about today. And by the way, it's not an all-inclusive list. It's just my top drivers. This one I think is the most important one, and it's the one that's the hardest to solve for. Oh, sorry. Again, my slide got away from me. It is the fee-for-service model. So basically, what we're talking about here is that in the United States, the way that we have designed our system and the way that we are paid for care is by the care that we give. So as a physician, I am in no way penalized if I order more tests or I see you more times, or there's no penalty. The penalty happens on the employer side, who's completely divorced from the actual decisions on this care, but they get the bills, right? So, if and of course it's even worse in the situation of defensive medicine, where you've got doctors that are like, well, I don't really need the MRI because I know this guy has XYZ, but just in case, I should get it because no one's going to argue with an MRI, and they could tell me that my clinical decision wasn't good if for some reason I'm wrong, even if it's a very low percentage chance that I'd be wrong. And so these decisions are made defensively, and they drive costs through the roof. I mean, the fact that it wasn't too long ago when any person who walked into an emergency room who had a head injury of any type would get a CT scan. Okay, well, that's just really unnecessary, but it was a lot better for the facility to get the CT scan and say, see, no bleed. Well, of course there was no bleed. We knew there was no bleed. They were completely neurologically fine. They were talking, walking, and everything was good. But once in a blue moon, there's a person who's like that, who then goes on to actually have a bleed. And so because of that, countless millions and millions of dollars have been spent on, really useless CTs to just prove something that we already know as clinicians is the fact. So, so those are the kind of things that in our model, it just, we make decisions that don't make any sense. Now, one of the most important ways that this is going to play out for us, if we don't do something about the way that our system runs, is that now we have telemedicine, and it's kind of ubiquitous in healthcare. COVID has made telemedicine a way that we do business, and a way that patients get care. Well, it's really a problem if a patient is getting used to telemedicine, and they're sitting on their couch and they're dialing their doctor every night. It's harder for patients to overutilize medical care if it's a little bit more difficult to get. And so you could see how if an employer is paying every time a person dials up a telemedicine doctor, and then they figure out how easy it is, that could really drive costs through the roof. And so people are worried about that. There's a lot of talk about what we're going to do about that particular problem. So, we're trying to figure out how to bend the cost curve here. We've got a problem that is just out of control, and we need some solutions. So there are a lot of innovators in healthcare right now, and they are working hard on this problem. And I'm going to just tell you a little bit about what we're doing at Next Level, but I'm using it basically as a proxy for what I think a lot of people are doing. So I'm going to tell you about a product that we've launched that is taking aim at some of these healthcare cost drivers. But there are a lot of other things that we can, there are a lot of other products that I will tell you about a little bit too. So in our product, it's called Next Level Prime. What we tried to do is first address the whole fee for service. So the first tenet of the product is that it is a membership model, and that we do not charge more for doing more. So for the membership price, an employee would be able to access the care however many times they want. The other tenet is, one of the things that's been an issue and that I kind of mentioned was this idea that people have a hard time understanding where they need to go in the healthcare system. So we decided that the first stop for any person who has Prime should be their care navigator. So basically a personal concierge who would help you to understand what would make most sense with the problem that you're having. So if you contact if you're a Prime member and you press the button, you get your concierge, and the care navigator tells you, you tell them what's going on, and the care navigator says that makes a lot of sense for me to put you on with one of our telemedicine doctors, or that really sounds like a problem that would be better suited for the emergency room. Why don't you head over there? I can help you find the closest one if need be, that kind of thing, or hang up and dial 911, whatever that needs to be. So, but what we're doing is we're basically helping the employer to ensure that their employees have somebody that can help them make the proper choices, so they don't end up in a situation where they just made the best decision they could and it was completely wrong. The next tenet of the product is that we are giving people access to care outside of what the normal healthcare hours are. And the reason that this is so important is that when you go back to my cost driver slide and you talk about inpatient hospitalizations, and you realize that people are not getting basic preventive care, and one of the biggest reason they're not getting that care is because they don't want to take off of work to do that. We are a very busy country, and we don't have time to do things like take good care of ourselves when there's bosses to satisfy, and there's work to be done, and there's a paycheck that you need to bring home. So what we're trying to do is solve for that by saying you can get your annual physical on Sunday at 3 p.m. You can get your diabetes checked at 7 p.m. on a Thursday night. So, that access to both preventive care and chronic condition care, but at hours where people really do have the time and they can do this, even if you think about just, your own day and what happens in your work day, and the fact that you're not feeling well, but who has time for that, right? So you just kind of power through. Well, if you had a service where you aren't going to pay extra if you use it, right? And you're going to get home, maybe you'll make dinner, maybe you'll, help the kids with their homework, and then you'll say, oh my gosh, I still feel really bad, but I can go in, I can get this taken care of. So it's, exciting for us. Narrow network. And then this is, we were talking about out of network, and everyone was really focused on this over the last few years. People have been really focused on, these out of network costs and how do you get people to be in network. And that was sort of, I think, taken to a little bit of an illogical extreme, where they made these super narrow networks where you tell your employees, well, you can only go to these people, you can only do this, you can only use this hospital, you can only use these specialists. And that is not seen as a benefit by your employees. So it's smart, it saves money, but employees kind of tend to get a little pissy when you tell them, well, you can't use the person that you've always used or that your friend says is the best doctor in the city. And so what we wanted to do was make sure that our product allowed people the choice, so they can go to any hospital system, they can go to any PCP. This is just a layer on top of it that helps care navigate, so that, yes, well, let's talk about that person. That is the person that your friend recommended. They happen to be out of network with your plan. So it's going to cost more. That kind of conversation where your employees can help make some intelligent decisions based on knowledge that they don't really have right now. Technology enhancing in-person care, not replacing it. What I mean by this is that, the telemedicine is not the magic bullet. It doesn't work in all cases for all things. So when people say, oh, well, you should just use, we can use telemedicine for everything. Well, some people really want to be seen in person. That's number one. But number two is that I think telemedicine has a really important role. And for sure in chronic conditions, you can use telemedicine as something that you can insert between in-person visits. And so you get this enhancement. So you get more touch points, more opportunity to talk to a healthcare provider, but that it's not like replacing it. And so I think that there's, this shouldn't be an all or nothing thing. In sort of as a follow-up, a corollary to that is what we're planning to do with our product, or have done, is that we've created sort of a hybrid model of visits. So for example, in your annual wellness exam, you would have a component that was virtual, and then a component that was in person, and then your third component would be also virtual. So you would start with a extensive health interview with a medical provider that would take a detailed history and really understand everything that was going on with you as a patient. Then they would tell you, okay, you're now ready. I'm going to put this visit on hold. You're ready. Anytime it's convenient for you, day or night, you can come in and get your full examination and your lab work drawn. They don't have to talk to a doctor. I mean, short of just, hi, how you doing? I'm here for my physical. And that way, the person who's on site can do the in-person care. The patient can get it done quickly. They can get it done conveniently. But the next follow-up, which would happen the day after, would be that they would get back together in a virtual setting, if they so choose, by the way, and they could review the results of their exam, review the results of their labs, and have a conversation that was not while they were sitting, in a gown on a cold, plinth, waiting for the doctor to tell them something, important. So this is it's a method of using the tools that we have, this incredible opportunity to talk to people in a comfortable setting, but then not forego the important objective findings of a physical examination and of lab. And finally, of course, our product, we've got 16 locations around town. So we're trying to make facilities convenient to the patient population, your employee population, so that people can get the care that they need easily. So just a quick moment on key features of this particular product, and you can see how easy this is. Our app, and this is the Next Level Prime button. So you would just push this orange button and you get a care navigator right away. So that's the care navigation piece that I think, is so important. And like I said, we're not the only people that are promoting care navigation. You will talk to a lot of people out there that have products that do this. What you're looking for your employees is somebody who's not you, who can objectively give them good information about where they should get their care, because believe me, it is not easy to understand. And I know from being a physician and having been burned a few times that I can't expect a person who doesn't have a lot of in-depth healthcare knowledge to understand where they're supposed to go at all times. Another key feature that we've baked into our product is formulary management. So what this is that when we engage with an employer purchases Prime, their formulary gets loaded into our system. So when we see one of their patients, our physicians are presented with medication choices that make sense for their formulary. So we don't put the top medicine as the most expensive medicine that an employer would have to pay for. But again, we are also physicians, and we're also very, we need to make decisions that are the right thing for the patient. So, if there is no generic for their condition, then, it is what it is. But at least the employer has the sense of satisfaction that if there is a generic, that it has been offered. And if there is a lower cost brand name, then it has been offered. And another cool feature that we think is really important and should be important in any product that you choose is the ability to choose referrals, specialists that are not out of network. And so the way we do that is we have technology that actually shows us the available appointments of all of the different specialists in an area. And when we engage an employer in Prime, the employer can tell us what hospital systems, what specialists are in their plan and are the most cost effective. And we can see those first. Our providers, when our doctor goes to see the patient and says, you really need an orthopedic surgeon, they can see the list of orthopedic surgeons based upon their the people being in network, and then they can book an appointment for them. So how does, something like this save money? And obviously we've kind of gone over it a little bit, but you're going to reduce non-emergent utilization of the ER. If employees are using care navigation, any kind of care navigation, you're going to save money on the ER visits. You're also going to save money on the ER visits when going to the ER directly costs more money. So with employers that are self-insured, they have the ability to build their plans the way they want. And so they can actually build these things into the plan like, hey, if you talk to a care navigator and you went to an ER, it's this. If you didn't, then it's this. And I think that those kind of things will ultimately, change the behaviors of your population. This will also increase PCP relationships and annual physicals. Before I got into this, I thought everybody had a primary care provider. And then when we opened Next Level, our first question that we ask patients when they come in is, who is your primary care provider? Because we like to communicate with the primary care providers. About 55% of our patients do not have a primary care provider when they come in to see us. So we want to change that. And this is one way to do it. Make it really easy, no excuses. What were you doing on Sunday at 2 p.m. that you couldn't have come in and gotten your physical taken care of? Increasing chronic care compliance. Of course, we talked a little bit about wellness, but once the patient is within the system, they can actually be talking to medical providers and set up a care plan for the year. And again, if we're making great use of virtual care, then we're really trying to make it super convenient for the patient so that they don't have a reason not to do it. And I think also medical providers understanding that it's highly likely that the patient is going to have something that they prefer to do than take care of their diabetes. No matter how easy you make it, we have to reach out to them. We have to engage. This is, going to be, I think, what changes, what can really change the cost curve is, really patient engagement. So those kind of things that you do that will get a patient to do it even if they don't like it. We happen to have lower specialist referral rates. So in, this is just a slide that I tell people about Prime. So this is on there. But, I obviously their specialists are important. They should be used when necessary, but it's kind of like ERs. You don't need to go to an orthopedist if you have a straightforward fracture that doesn't need surgery. You can get that cast anywhere. Well, you should be able to. You can't, but it's an easy fix, and you don't need a specialist for that. You don't need that cost. So we try to work on that. And then lower laboratory DME immunization pricing. There's a lot of things that happen in medicine where costs can creep in. And so, as an employer, you have to be aware of everywhere that you're getting charged. And again, I'm really speaking to self-insured employers because, if you have indemnity insurance and you're just, doing your thing, none of what I just told you matters. I mean, you're paying a very high price that the insurance has made sure that they're going to win. And so, and then your people can do whatever. So that's one option. But if you're trying to figure out how to not have to pay those exorbitant fees, you're probably going to go into a self-insured model. And that's when all of this stuff that I'm talking about really matters. So, I did want to mention one product. I actually had a fantastic conversation this morning You know, I run into people when you're really excited about cost in healthcare, you get to talk to a lot of interesting people who have brilliant ideas. And, you know, the problem is that we're bucking up against a very entrenched system. People aren't used to thinking about anything but fee-for-service medicine in the way that we have always done it. And even employers like me, I get nervous to tell my employees we're going to try something unusual, because you know, you want to make sure that they think you're giving them a good benefit. You don't want them to feel like they're getting a worse benefit. So I talked to a gentleman this morning, and he runs a I don't even know what you would call it, but it's a cost sharing, I think he called it. He It's a company called Sedera, and employers can enroll their employees, and it's a fixed monthly cost, but then the employee doesn't have insurance, so they are going to a doctor's and saying, what's your self-pay rate? And then the employee is given the self-pay rate. They actually do help negotiate those rates with, if there's room for negotiation, those rates are negotiated. And then the employee actually pays the bill, and the company, the cost sharing entity, then reimburses the employee. And what this guy said was, well, it really makes employees or the patient very cost conscious and very responsible for, you know, makes them a consumer. But you know, it also dramatically lowers the cost of healthcare, because frankly, if you have insurance, then you're just the bill's just paid, right? And nobody asks, could it be lower? But in this you know, venue, you can, or on this platform, you would be asking people, well, what's the best price you can give me? It makes you know, healthcare into a more consumer centric you know, industry, which is interesting. So I say this just to kind of let everyone know that there are a lot of people working on the cost of healthcare, and the future, I think, is going to look different than it looks today. And I do think that COVID has accelerated the need for change. I think employers are going to be the ones that drive the change. I think employers are going to look at these bills, and at some point, all of us are going to say, holy cow, enough is enough. What can we do about these problems? So this slide is just what I think might happen in the future. I think we're going to definitely have more virtual engagement tools. I think patients are going to get a lot more comfortable with doing things remotely, and that will bring down cost if we can get away from fee-for-service. I think there's going to be more concierge care, because I think that actually somebody helping people, if there's more guidance, and there's more one-on-one, and there's a little bit more personal touch to healthcare, I think that will actually tend to bring down costs. We are living in a convenience world. Everybody wants everything to be like Amazon and or Google, and that is, I think, what is happening in healthcare too, is we're getting intense pressure to be more user-friendly, and to be more convenient, and to be you know, ready at a click of a button. And so, you know, that's what I think we're going to see a lot more in healthcare. I do believe that someone is going to help us lower drug prices in this country. I think that it's very much hit the national, you know, hot topic list. And I think that as some political candidate or another will make a very big push for this, because I think it will gain them a lot of political capital to solve this problem even a little bit. So it's a very big problem. And then finally, I think, you know, I'm hoping that healthcare will become less confusing for all of us, for consumers, and, you know, bills will become less confusing if we could knock out some of this craziness of it's this price, but then there's this adjustment, and then there's this price. Why can't it just be simple? If it was a membership, or if it was something that you could understand, I think that would be really great. So those are again, my opinions, and certainly they're shared by some, but not all. And I would say to you that, for me, I am trying to, be the change I wish to see in the world. I think this is the actual quote that Mahatma Gandhi said, but I think people have paraphrased it and well. And I do think that all of us, and especially if I have employers listening who are in charge of the healthcare of their employees, be that change. Try to help to look for solutions and look for innovation and drive our economy in a different way, so that future generations aren't dealing with the incredible costs and complexity that we've created in the current system. So that's all I had. I don't know if there are questions from the audience. I can't see them, so I'll have to tell me.
Thank you, Dr. Breeze. Just a couple that we came through, and thank you for the insightful presentation. Very, very knowledgeable and great for our businesses to hear. What size organization, as you're talking about the Prime, what size organization do you need to benefit from the Prime?
So, like any size, actually. You can be a very small employer. Now, what we're finding is that a lot of employers who have recently been told that they've just hit the size that they need to provide healthcare for their employees, those are the most interested in trying to figure out, well, how do I do this and not completely break the bank, because this was a line item that they didn't have before. The other types of employers that we're talking to quite a bit right now are, mid-size and larger employers who have quite a few employees that are lower paid, lower wage workers, because the lower wage workers preferentially choose the very high deductible plans because they can't afford the premiums for the richer plans. But what happens is that then they're literally paying for their healthcare out of their pocket 100% of the time, because if you have a $5,000 deductible, most people aren't really ever going to go through that in a year, and so they're just paying out the money, and they don't think their employer gave them any kind of a deal at all. I mean, that's not a benefit. And so those employers are saying, can I buy the membership model for those people so that they are not paying anything for their televisits, and they're only paying $20 when they walk into a facility. That's affordable, and it's a real benefit. People will be appreciative of that benefit versus, here's your insurance, if you're lucky and you don't have, a major crisis, then you will never even use this at all.
Right. Well, thank you. And then one more, can you go into, again, explain how shared saving plans works for the businesses to save their money? I think you touched on it, but if you can just recap that one more time for us.
Yeah. I mean, I think and I'm not a total expert, because I literally just had this conversation today about this one group that's doing it. But my understanding is that they are paying a certain amount, flat amount, just like a membership, every single month. And then their employees are able to go out, and they have a minimal, what he called it, an initial unshareable amount. So the employer sets the initial unshareable amount, and let's say that amount is $500. If you have anything under $500 that you have as a medical expense, then that is not part of that shared model. So it's got to be higher than the unshareable amount. And once it goes above that, then you tell the, you bring that bill back to the pool, and the pool pays for it. But before that, your employees are basically saying, I don't have insurance, what's your self-pay rate? And then they're getting immediately reimbursed for whatever they're paying. Because in general, in medicine, doctors will make, or facilities, hospitals will make deals with self-pay patients just because they know how much their real costs are. And it sometimes has nothing to do with how much they're getting paid from insurance. And one, quick example, because I think that, this sort of, just puts a, point on this whole thing is, we're in the midst of doing a lot of COVID stuff. COVID testing has been a big thing. We are doing rapid COVID testing at next level urgent care places. And so we have a 15-minute test for COVID. We are charged for that test. We have to buy them. And so we have put almost a non-existent margin on that test. And we charge $75 for people to get that test. I recently was in a group of women that were talking about having to get COVID testing and bringing their kids and having their families. And in that group of women who were talking, we had one person who got their test for $200, one person who got their test for $275, same test, by the way, exactly the same. And one person went through insurance. So she said, well, I didn't even have to pay anything. Well, she called me and let me know that her insurance paid $750 for that test. So I think that that just sort of goes to show you that U.S. healthcare is a mess. And, the best thing we could do is start to really push on the powers that be and create new ways of doing this.
Well, thank you for being an innovator and a leader in that space for us. If you have any closing remarks, feel free to throw them out there. But if not, thank you again for today. We always enjoy having you, and we look forward to next time.
Absolutely. Well, it was a pleasure, and I appreciate you, having me to speak. And of course, for anybody who gets to hear this presentation or has heard it, you are always welcome to reach out to me personally. My email is jbreeze@nlucc.com, and I'm always happy to answer questions or have a discussion about these kind of topics. It's my passion.
Well, thank you again. You guys have a wonderful day and a wonderful weekend as well.
All right. Take care.
All right. Bye, guys.